Very good afternoon. If you've just tuned in, you're listening to myself, Jay Richards, here on the Midweek News Roundup Show. Now, this week on my show, I'm interviewing Dr. John Campbell, who is a UK-based health and science communicator. John, welcome to the show.
Jay, thank you for having me. It's great to be here.
John, could we start by you explaining a little bit about yourself for our listeners, please?
Yeah, certainly. I'm a bit of a strange phenomenon, really. Many years ago, when I was 18, I started off as a psychiatric nurse. Then I did general nurse training. And then I did quite a few jobs in the UK and around the world. But I always wanted to go into teaching. So I went into nurse education as a full-time nurse tutor, we called it in those days. And then in his wisdom, Tony Blair decided to move nurse education into higher education. So I actually became an academic. So I kind of went down the academic route after that and did various science degrees and eventually doing a research degree, which was a doctorate. That's why I'm allowed to call myself a doctor, because it's a research doctorate degree that I've done that's in nurse education, the contents of basically physiology and pathophysiology, the study of disease, and how you communicate that around the world. And now I'm semi-retired.
Absolutely fantastic. So before we start talking about COVID, let's talk about previous epidemics, as there have been quite a few in the past.
You know, it's a really interesting question, Jay. People these days, you know, we've been privileged enough to be brought up in the era of antibiotics. You get an infection, you go to the doctor, and basically it goes away. And the viral infections that cause massive disease in the past, like polio, we've largely vaccinated against those, or smallpox. So infectious disease is something that we don't really live with quite so much as previous generations. But throughout human history, infectious disease is really what has killed people. And of course, it is still a big problem in many poor parts of the world. Some of the biggest problems in children are gastrointestinal infections causing diarrhea and vomiting and dehydration, and respiratory infections are really common. And of course, in 1348, the bubonic plague arrived in the UK. No one's really quite sure how many people that killed. It probably wasn't less than 40% of the population. Could have been 50% of the population. Just imagine that sort of situation where half of the people that you know are dying through infectious diseases, and you really don't know why. Family members dying, friends dying, you know, society basically breaking down as a result of that. And if you think about smallpox, you know, some people estimate that smallpox killed 300 million people in the Americas in the past. So, and then 1919, what we call the Spanish flu, that probably killed 50, 60, 70, even 80 million people around the world. No one's really quite sure. So we've just lived in this sort of cocooned period of time, really, where we haven't had infectious diseases. And that's partly why everyone's been taken by such surprise by this current pandemic, because it's not really what we're used to.
Now, you mentioned polio a moment ago. When polio was prominent in the UK, it took the best part of 20 years for that to disappear. How long do you see COVID-19, now called coronavirus officially, lasting?
That's a really good question, Jay. I think the question is, how long would we like to keep it for, and would we like it to go away quicker? Because if we all act together, we can make it go away quicker. So therapeutics are available now to some extent, and more therapeutics are being developed. So that's all good. But the long-term way out of this pandemic is vaccination. And there's a reliable saying in this that says it's not over for anyone till it's over for everyone. And there's quite a bit of truth in that. So basically, my view is we have to vaccinate the majority of people in the world. Now, that might sound quite horrendous, but the majority of people in the world are already vaccinated against tetanus, for example, and other infectious diseases, or measles, mumps, rubella, and all the other diseases we now vaccinate against. We just have to add this one on. But of course, we're playing quite a lot of catch up on this because this is a novel virus. It's new. This virus has not circulated in human populations before. That means the human immune system is naive to this virus. So the immune system has to be educated. And there's only two ways to educate the immune system. That is to suffer from the actual infection itself, or it's to suffer from a simile, if you like, of the infection, which is what vaccination is, that makes the immune system think it's been infected by the actual organism, the virus in this case, and produces an immune response. So basically, I think we need to roll out a global vaccination program. Otherwise, we're going to get rid of this virus, not entirely. We're entering what you might call the endemic phase in this country, where it's going to be rumbling along at a low level for some time. And that could go on for several seasons. I'm hopeful we can get rid of it altogether, but we don't know that yet. But in other countries, there's going to be big flare-ups. And when there's big flare-ups of people that are not vaccinated and haven't had the disease, there's going to be a lot of viral replication. And whenever this virus replicates, there's the possibility that it will mutate and we could get further variants. And we're still in a bit of a learning curve, in fact, a steep learning curve into what these variants do, how they affect the transmissibility of the virus, and how they affect the pathogenicity of the virus, how sick they make people. And you know what, Jay, basically I'd like not to find out. I'd like to get enough people vaccinated so we never really find out how dangerous variants and mutants of this virus could potentially be.
Now, before we move on to vaccines and the various vaccines that are available, I'd like to talk about herd immunity. I've actually had a professor on my show on numerous occasions, and we've spoken about herd immunity, and it's believed that herd immunity will never be achieved. What's your opinion on this?
Well, as you say, there's two views on that. My view is herd immunity certainly can be achieved. Now, with the original strain of this virus, when it came out, it had a certain level of transmissibility. And most epidemiologists estimated at that time would need about 70% of people to be immune to this virus to generate herd immunity. Basically, what that means is if I am infected with the virus and I bump into you and you're immune, I can't pass it on to you, so you can't pass it on to your colleagues or your partner at home or your children or whatever. It's kind of like a fire break around the virus. So it looked like it was about 70%, and that did look pretty well achievable through some people having the infection and mass vaccination. But now with this UK variant, the B117 variant, sometimes called the Kent variant, that is more transmissible. So it's now looking like we'll probably need about 80%. And Dr. Anthony Fauci in the States says possibly even up to 85% of people to be immune to achieve herd immunity. So herd immunity is possible, but it's all the harder at the moment. So we need to roll out this vaccine to a wider swathe of the population. And because young people constitute quite a big swathe of the population, we're going to need to think about vaccinating adolescents and potentially in the next year or two, vaccinating children to get the numbers high enough to get those percentages.
Can we now move on to variants? We were speaking off air before we came back about the various Indian variants that we are now seeing. What do we know about these Indian variants?
Well, variants do seem to arise around the world, and we seem to have a habit of naming them according to where they arose. So people tend to talk about the UK Kent variant or the South Africa variant or the Brazilian variant. And this one was first identified in India. And its code name is B1617. But there's kind of an evolutionary process going on here. So it's kind of evolved into three strains, actually. So we have that original B1617. Now we have the 0.2 and the 0.3 versions. And it seems to be the B1617.2 that is causing the particular problems and seems to be more transmissible. Now, there are probably 500 or 600 or more cases of this in the UK now, which is something interesting we're keeping an eye on. But it has increased transmissibility, and that is part of the reason it's transmitted through India so quickly. So perhaps the reason that this second wave is causing so many more infections in India is the increased transmissibility of the virus. But of course, you've got the biology of the virus, and that's always combined with the host, with the human host. So in India at the moment, we've had the religious festivals like the Kumbh Mela, where literally millions of people go and bathe in the Ganges for religious, spiritual reasons, which that part's not so bad because that's outdoor, although it is pretty crowded. But the trouble is people will be staying in hotels, and because they want to do it cheap, they'll get 20, 30 people staying in a room. So basically in that sort of situation, you've got guaranteed transmission. There's been a lot of political rallies. And of course, the living conditions in India are difficult at the best of times. And also another factor which might be coming into play here, surprisingly enough, although it's very sunny, a lot of people in India are actually very deficient in vitamin D, which could be potentially affecting the immune system. And you've got this new variant. So all these things have come together somehow and synergized into this massive explosion of the pandemic that we have in India. And basically, so many people are getting infected. And when a lot of people get infected, of course, we know that a proportion of those get sick and require hospitalization.
Sure, yeah,
and in India, hospitalization can be difficult at the best of times, especially in rural areas. So you've got this kind of double whammy of a certain percentage of people getting sick or requiring care at the same time, very challenged healthcare facilities already. And basically what this means, and this is tragic, of course, it's absolutely heartbreaking to see people dying who could have survived had they had what is often fairly basic treatment. So if you think of our Prime Minister, when he was hospitalized, he wasn't ventilated, but he was on oxygen for several days. And that's a fairly simple thing. Anyone can put oxygen, any clinician, any nurse or doctor in hospital can put oxygen up. That's not hard to do as long as you've got the supply. And, you know, it's fairly simple to monitor it. We all learn how to do this. And if he hadn't had that oxygen, he probably would have died. Because with the oxygen, he said there was a time where it could have gone either way. Now, that means he could have died or he could have lived. But because of the oxygen, it was finely balanced. But the oxygen was probably the thing that made him survive. And it's just tragic to think of people dying just through lack of such basic things and even basic drugs. You know, the deaths are tragic, of course, but deaths are inevitable. You know, we are mortal. But unnecessary deaths are something else. If there's a death and you feel you hadn't done everything you could, that is the ultimate tragedy in healthcare, and that's unfortunately what we're seeing.
So I'm going to ask the big question, Doctor. When do you see this pandemic ending?
That's a very good question. In the UK, you know, I'm pretty optimistic. I think the vaccination program's going well in the UK. The vaccines are being well accepted and people are taking the vaccines and it's being rolled out to younger age groups, which is absolutely brilliant. So I think we're going to reach, I hesitate to use the word, but it's possible we can reach herd immunity in the UK, or at least the level of immunity that's going to greatly slow the transmission down. And as well as that, we know that whatever vaccine you've had, it doesn't matter what vaccine you've had, once it's had time to work, especially if you've had 2 doses, then the likelihood of getting seriously ill, being hospitalized or dying goes down absolutely dramatically. And we're seeing this now. You know, if you think about the deaths we were getting at the end of January to the deaths we're getting now, you know, they're massively down now because we're vaccinating the vulnerable groups. So even though there might be some rumbling on of this disease in unvaccinated people, and even some transmission, it has to be said, in vaccinated people, it's going to be more of an intercurrent illness and more of an inconvenience and not a cause of mass mortality as it has been in the past. So I think it's going to become less significant for us because less people are going to die, but it could rumble on for a few seasons, unfortunately. Now, the situation in poorer countries is different. That's going to depend very largely on the vaccine rollout in poorer countries, and it's going to depend on the use and implementation of therapeutics. Because if you imagine that you had a drug that could suppress the amount of virus in someone's body, then if the amount of virus is low, the amount of virus they're shedding is low. And we know the likelihood of someone getting the infection depends on the viral load they experience. That's called the inoculum of the virus. So all of these things could massively reduce the spread. So Western countries, Europe, the United States, optimistic. Third, what we call third world or developing countries, the problem could go on for quite a few more seasons.
So I'd like now to talk about waves, if that's possible. We've seen multiple waves in the UK at the moment. When do you predict the next wave will hit, and where do you think it will hit?
Good question. So in the UK, of course, we had the cases went up to begin with. Then we had those lockdown measures and they went down. And then things were fairly low last summer. You know, more people outside, more vitamin D in the sunshine, less indoor gatherings. But then in autumn, cases started to go up. And then we had that tiered system, if you remember. We started off with 3 tiers and it all got a bit complicated and cases went down again. But then we had the new variant, the B117 hit, and then cases absolutely took off again. And that's how we had that great peak in December, January. Now, whether you want to call these waves or not, or whether you want to say it's like an extension of the same wave, is a bit semantic, really, because it's basically the same virus or new variants of the virus. So waves, I guess what a wave is an increase in the incidence of the condition. So I think it's fair to say from that, using that fairly loose definition, we've had these 3 waves in the UK. And I am highly optimistic that because of the vaccination program and the increased knowledge that people have now, that we're not going to get another wave of that nature in the UK. I think in the UK, we're entering what we might call an endemic phase. So a pandemic, of course, is where an infection spreads everywhere all around the world. An epidemic is where it spreads all around a regional area. An endemic disease is one which is always there, sometimes at a low level, sometimes at a higher level. So, for example, malaria is endemic in Africa. It's always there. Dengue fever is endemic in Southeast Asia. It's always there to an extent. So I think this is going to be with us, causing less human pain, suffering, and death because of the protection against severe illness and death of the vaccines, but it could rumble on for a few seasons. I'm optimistic we can get rid of it in time, but how many seasons it's going to take to get rid of it altogether, we don't know. We may see, so I expect we'll see cases going down in the summer, but quite possible we'll see a few cases coming up again next winter because we know of this seasonal effect as the virus is transmitted indoors rather than outdoors where it's diluted.
Now, last week I spoke with Professor Paul Hunter, who is an epidemiologist at East Anglia University, and we were speaking about the Johnson & Johnson and Moderna vaccinations. And now there's also a Novavax, which we were talking about before we came on.
Yeah.
What's your opinion on these new vaccines?
Well, all of these vaccines are new. So we've got the Pfizer and the Moderna vaccine, which are the messenger ribonucleic acid, the RNA vaccines, and we've got the AstraZeneca one and I get them all mixed up now. The AstraZeneca one and the Johnson & Johnson are both these viral vector. The Janssen Johnson & Johnson vaccines are the viral vector vaccines. That's the right way around. Now, all of these are new. These are new modalities of vaccination. So we are actually still learning quite a bit as we go along about these. But the Moderna vaccine specifically, we didn't get on the bus very early with that one. We only ordered that fairly late, but it's an mRNA vaccine, and that's actually working quite well. So that's looking good. The Oxford AstraZeneca one, again, a remarkably useful vaccine. Of course, the Oxford AstraZeneca vaccine is transmitted at, or you can carry it around the country just at normal fridge temperatures. Very convenient, whereas the Moderna and the Pfizer vaccines, you need the lower temperatures. And there's another one coming out soon. Well, I'm saying it's coming out soon. We expect it to come out soon, the Novavax. So we've got the Moderna and the Pfizer, which are new messenger RNA viruses. We've got the Janssen, Johnson & Johnson and the AstraZeneca, which are new adenovirus vector vaccines. Again, new ways of doing it. And now we've got the Novavax one, and this is a protein-based vaccine. So what happens here is the genetic code to make the spike protein, to make the antigen, is actually being put into insect cells. And you brew up these insect cells, and the insect cells produce this protein for you. You then purify it, you give it with an adjunct, and that's what the Novavax vaccine is. And the phase 3 trials have been done in the UK. And I'm expecting that we're going to get authorization, emergency use authorization for that one pretty soon, which would be good because it would give us a 4th vaccine. And I think this is important because we're learning now that particular vaccines are better for particular people and particular age groups. And we're also learning that if we give particular vaccines to particular age groups and particular sexes, we can perhaps minimize the side effects of the vaccine. So the more we get, the better, and we can optimize the particular vaccine we give for the particular individual that receives it, whereas at the moment, you're just grateful for whatever you can get.
Doctor, I'd like to talk now about the topic which is extremely controversial, conspiracy theories. The WHO sent a team of scientists to Wuhan to investigate the origins of COVID-19. But it was later reported that the scientists were actually not official WHO members. Do you ever think that we will get to the bottom of the origins of the start of the pandemic?
Yeah, that visit certainly took a while to organize and plan, didn't it? Basically, it took about a year, and the Chinese did sort of decide who they wanted on the team. Having said that, all the people on the team are recognized authorities in their field. But there's just some question mark over whether they appointed people that would not rock the boat too much. But anyway, they went off to Wuhan. They did quite a few investigations. It's interesting that before they went, they did play down expectations quite a lot. And when they came back, they basically didn't come with massively firm conclusions. But the World Health Organization did say at the time that this is not the end of this. We do want to investigate this further. So at the time when the report came back basically saying, well, sorry, we don't know, the World Health Organization was saying, well, no, we do need to know. And this is not finished. We're going to go on with this. But the World Health Organization don't really seem to have acted on that. So they made the right noises at the time, without the right kind of follow-up. Now, I don't think there's any serious scientific doubt, in my mind at least, that this virus arose in Wuhan from bat populations. Now, there's all sorts of ideas that the virus was around in Europe at an earlier stage. And there is probably truth in that. But the reason that I believe this virus did come from the China area is previous viral work in bats, particularly in that area, shows that the virus is most similar to other bat viruses in that area. So it would be surprising if something with that particular sort of genetic makeup spontaneously arose in Italy. Viruses evolve from other viruses. So I'm pretty sure it came from China. We're pretty sure it came from bats. But then that's basically all we know. So how did the virus get from bats into humans? Well, there was obviously some mutation in the bat because the coronaviruses are common in bats. But what animal host it went through, we don't know. And of course, the coincidence is that the Wuhan Institute of Virology, which is the main center for virology in China, with a lot of links to the United States as well, we believe, happens to be just a few miles from the epicenter of this pandemic. So people have rightly asked the question, well, is it just coincidence that this is just a few miles away from the epicenter of the pandemic? And the World Health Organization team didn't really answer that. So I think what we know is that this virus is almost certainly from that area, did spread around the world, perhaps quite a bit earlier than we thought, perhaps late summer 2019. Evidence for that in Italy and some other places as well. Italy and other places in Europe, I think, evidence for that, certainly in Italy. And how that jump occurred, we don't have anything definitive to say. Now, the intelligence agencies have told us that this is not a biosynthesized virus. And I think we have to believe them. The UK intelligence services and the US intelligence services have both gone on record and said this is not a lab-created virus.
Sure. Yeah.
So it's not a synthesized virus. But of course, it could be a virus that was taken from bats that was potentially worked on in a viral institute somewhere, who knows, that escaped. Because it's quite legitimate to work on viruses to understand virology and to develop vaccines. And of course, you've got to remember there was a similar disease in 2003, the SARS coronavirus 1. And indeed, there's still some outbreaks of a similar disease called the Middle East Respiratory Syndrome, which comes from camels. I believe that one went from bats into camels. So there's still some infections, particularly in Saudi Arabia, where it goes from camels to humans. But fortunately, that one doesn't spread around the world like SARS coronavirus 2 does. So basically, we're awaiting further information. Now, will we ever find out is the next question. And I suspect we will, but it's not going to be very quickly. Because as the science advances, we are going to be able to do more evolutionary studies, more genomic analysis, greater understanding of viral intermediates. And the truth probably will come out eventually, but it may not be in my lifetime. Let's hope it's in yours.
I'd like to dig a little bit deeper into the WHO, if that's okay, Doctor. How important is the evidence base, and how do we know what the truth is?
Yeah, that's a great question. This is fundamental. We have to be able to differentiate between truth and non-truth. What is the nature of truth? Now, how do we know that in science? Well, there's basically two ways that we understand that. So one way is that there's accepted facts in science. There's things that we know. So in physics, for example, you might have learned Newton's laws of motion. they're not going to change. Okay, you could modify them a bit with relativity theory, but basically they're not going to change. If you take medicine, for example, we have something called Robert Koch's postulates that describe how infectious disease is spread and identified. And again, that's not going to change. And we know a bit about the way the body works. We know a bit about the way viruses works. We know a bit about immunity. These things are basically accepted science. So we can apply these scientific principles into new situations. So that's one way we know about science. And if anything contradicts that, then we'd have to think very carefully about that. Because if some new discovery is apparently contradicting known science, we'd have to think very carefully, because we don't want to reject known science very quickly. We can do, but we'd have to have overwhelming evidence for that. But of course, the other way that we work things out is empiricism. And that basically means trying it out. So that's what a clinical trial is. We basically try it out. So you give out the vaccines to 30, 40, 50,000 people. So some have had the vaccine, some have had the placebo, and you find that more people in the placebo group get the infection compared to the vaccine group, indicating the vaccine has a degree of efficacy, a degree of protection. So that's the sort of clinical trial route. So ideally, we want things that are predicated on basic science and authenticated by empiricism, by empirical science. But of course, there is a problem here as well, because clinical trials, especially large-scale clinical trials, are expensive to do. Sure, so people who organize large-scale clinical trials want some return from that. And unfortunately, we have this system at the moment where a drug patent expires typically after 15 years. So if we have a drug at the moment, which may be effective against, say, SARS coronavirus 2, for example, but is out of patent, then the pharmaceutical industries, understandably, their businesses, have no interest in spending several million pounds on a clinical trial for something they can't make any money out of. But a new drug where they can make money out of, then they're going to do the clinical trials. So clinical trials are kind of self-selective, really. And this is kind of the problem with empirical science at the moment. It's financially orientated. And this is where governments need to come in. So if there's a potential therapeutic that might work, really government should take that on and organize the clinical trials, bearing in mind that there's no profit motive in this. But the way it's set up at the moment, clinical trials are mostly done by people that can potentially make a profit from them. And that is a bit of a problem. But it doesn't alter the fact that we find truth in empiricism. If it works in the real world, that is the key test. If something works, if that contradicts the theory, then relook at the theory. But we want to know what works. But the way we find out this is largely by this clinical trial modality in healthcare.
Now, the government's just released a list of green zones that we can travel to. We were talking
smallest, it has to be said.
It is indeed, yeah. Can we explain to our listeners why the UK and particularly Israel, followed closely by the USA, is at the forefront of vaccinating their population in comparison to the rest of the world?
But when the COVID thing started back in January, February, we accumulated some reliable sayings. And one of those was we need to move from reactivity to proactivity. So, for example, in my view, the World Health Organization was very reactive in limiting flights from China sometime after the virus had already spread around the world. And this is where the UK actually did really quite well. So there was a committee on immunization set up April, May 2020. And what they did was they realized that, of course, we're going to need vaccines. And at that time, we didn't have approved vaccines. They were all being developed. So the UK put money into about half a dozen vaccine programs.
Quite a big gamble, really, wasn't it? Dan?
Oh, very much so. But there again, it wasn't a gamble because they bet on every horse. So the GlaxoSmithKline Sanofi vaccine based in France, we put money into that, but that didn't work out. That's still, it will work out eventually, but it's years behind. So basically, we bet on every horse. But you're right in the fact that at that time we didn't know if vaccines were going to work. So we have no vaccine, for example, against HIV. You know, it's not automatic that you can make a vaccine against all viral illnesses because of the rate of mutation in this process called immune escape. So the UK put its money in the yes, the vaccines will work basket, We put a lot of money in that. And then we put money on every vaccine that looked like a reasonable contender. Now, one of the vaccines we didn't put much money into, unfortunately, was the Moderna one. So we actually came to that party late. That's why we're just getting supplies of the Moderna vaccine now. But we put money in the Pfizer pile. And then as soon as Pfizer came out, we had sort of a reserve on 40 million doses. We put money on the Oxford AstraZeneca vaccine. As soon as that came out, we had reserves on 100 million doses. Whereas the European Union, and this is not to make any political point at all, but the European Union didn't order their first vaccines and believe it was in August. So May, June, July, August, that's 4 months delay. So we were proactive. And as soon as the clinical trial data came out, that means our authorizing agencies were able to look at that trial data, decide if the vaccine was efficacious, decide if the safety profile was acceptable, and then give an emergency use authorization, which is why we started out early. And as you rightly so, of the larger population countries, Israel was very proactive and has vaccinated the largest majority of its citizens, and the cases and the deaths are going down dramatically now. Life is basically back to normal, I hear now, in Israel. UK is pretty close second in terms of per capita. And then the United States. A lot of vaccines are produced in the United States. And the United States they're rolling it out quickly. And at the moment, actually, vaccine supply in the United States is higher than vaccine demand. Whereas in the UK, the demand is still higher than the supply. So I'm expecting the UK to remain ahead of the United States in this vaccine rollout. And the reduction in cases that we're seeing now is in large part due to that.
Sure, yeah. Doctor, if you had to give any advice to people considering holidaying,
oh dear, yeah.
What would that advice be?
That's a dangerous question, Jay. Very dangerous question. I couldn't possibly advise anyone on their particular plans. But the European countries, for example, are rapidly catching up with their vaccine rollout now. So I am expecting herd immunity to develop in the UK as the vaccine program goes on. And European countries are catching up rapidly. So we've already got sort of precedent for this, you know, that Australia and New Zealand, for example, have got mutual deals. So I think what we're probably going to see is perhaps bilateral deals, perhaps European-wide deals on reciprocal travel once the numbers get low enough. But we're not quite there yet, because the only major country on that green list at the moment, I believe, is Portugal just now. But Spain and France could well be added to it in the next few weeks. So my firm advice would be, if you'd like to book a summer holiday, roll the dice and take your chances.
Do you know what my main concern is? You mentioned Portugal a moment ago. I was actually considering going to Portugal myself. However, I'm unaware of who's actually on their green list. But I think people need to be aware that it's not just the country that you're visiting, it's the country's green list themselves. For example, Lanzarote at the moment is at its highest peak. If the Portuguese community are allowing people from the Canary Islands into their country, you're then potentially putting yourself at risk from a mutated strand.
You are, but all the data we have at the moment indicates that if you're fully vaccinated, the probability that you'll get very sick or hospitalized or die from that is massively, massively reduced. And basically, there has to be some liberalization for the economy to continue. So the Centers for Disease Control in the United States, for example, has given advice that people who've had 2 doses of the vaccine, or indeed 1 dose of the Janssen vaccine, in other words, people that are fully vaccinated, are allowed freedoms that other people are not allowed. And I think that's got to come. The question is, how is that going to be evidenced? Now, the UK government is very reluctant to go down this because for some reason, I don't fully understand, they see this as discriminatory. I would see it as protective personally.
Sure,
but I think we are going to need some form of evidence for your immune status. Now, the government might not introduce this, but I think airlines will. Sure, and we already know that European countries are going to introduce this, and many other countries. So if you want to go on airline A to country B, both of those are probably going to insist on evidence of full vaccination. Now, we have the NHS app on our phones to check for contacts. And if you look at the moment, there's no evidence of vaccination on that. But my understanding is that is coming, that there will be a section of the NHS app where it gives your vaccination status. And my anticipation is you won't be able to get on an aeroplane or a ship or go on a cruise or go to certain countries without that evidence. I don't see any way around that at the moment.
On a final note, Doctor, I'd like to talk about lateral flow testing. How reliable are these lateral flow test kits that we get from the pharmacies?
Yeah, well, the lateral flow tests are reliable if someone has a high viral load. So they're actually authorized. The reason that these are introduced is to identify people with a high viral load, whether they're symptomatic or asymptomatic, to prevent ongoing transmission, rather than for clinical diagnosis of the individual, where the PCR test remains the absolute standard. Because you remember, when people get the first symptoms, we will call that day one. So the most infectious, like 24, 48 hours before that and 24, 48 hours after that. And that's when these lateral flow tests are likely to show a positive. And they don't show many false positives, only about 1 in 1,000 are false positives. But of course, if you were positive on that, ideally you would go on and get a PCR test anyway. But they can show false negatives. So if it was like 3 days before someone became infected or 3 days after someone became infected, especially if someone doesn't swab on their tonsils, to actually swab directly on your tonsils is quite a hard thing to do. So it's not a vague swab in the back of the mouth. It actually should be on the tonsils to get the viral load that's required to trigger that test to become positive. So it's not particularly reliable, actually, because you can get quite a lot of false negatives. Now, that's okay. It's still a guide. But the risk is that people say, oh, my lateral flow test was negative. I can go and do this, that, and the other. You know, that's not the way to look at it. But the PCR test will detect absolutely anything, because the PCR test is every time it has a cycle, it's doubling the amount of viral particles there. So even if there's a remarkably low viral load, the PCR test will still pick that up. So personally, you know, I've never been a massive fan of lateral flow tests, but we have to go with what the government is advising, and that's currently what the government's advising. So we have to go with that, because if we don't have government, we have anarchy. So let's make the best of it.
And from what I can understand, these lateral flow tests are extremely time sensitive as well.
In terms of the phase of the illness someone's at, yes, I think they are, because they're only going to trigger the they're only going to recognize a high viral load, and that is immediately before and immediately after symptoms. So people could still be somewhat transmissible and still get a negative, and potentially get a negative lateral flow test. Yes.
What I was actually meaning was the actual result is literally only valid for 30 minutes after you've done the test.
Oh, yes. Sorry. Yeah. You do the test. I think you wait 30 minutes and then you get the test, and then you have to read it at that point in time. That's true. Yeah. You have to make sure the control strip has changed color, and then you look for the other strip that would indicate the presence of the virus. If there's nothing there, then the test hasn't detected the presence of the virus.
Dr. John Campbell, UK-based health and science communicator, many thanks for coming on the show.
Thank you, Jay. It's been great to be here.